Hi everyone, I'm Connie. I'm the clinical consultant for chemical restraint at the Victorian Senior Practitioner's office. I'm a consultant pharmacist by training, and I've worked with the Victorian Department of Health for a number of years prior to starting this role about a year ago. So just to begin with, I would like to acknowledge the traditional owners of the lands that we're meeting on today. And for me, that's the Wurundjeri people from the Kulin Nation. I'd like to pay respects to the elders past and present. So today I will just talk a little bit about our office, the Victorian Senior Practitioner's Office, which I'm sure a lot of you are very familiar with, and the work that we've been doing since I've started in the space around chemical restraint. So my role was a new role that was created to tackle this issue specifically. And I look forward to working with the SPIDER team and probably many of you down the track to look at how we can better manage medications in people with intellectual disability. So our office, for those that are not familiar, our core function is to regulate the use of restrictive practices and compulsory treatment orders in people with an intellectual disability. And the reason is so that we can safeguard those individuals to make sure that when restrictive practices are used, that they're complying with appropriate standards and that it is indeed least restrictive for that person. We also provide practice advice to authorised program officers and to an extent behaviour support practitioners and any other relevant stakeholders or healthcare providers. We also have a core function of conducting research into restrictive practices and compulsory treatment. So that's quite unique for a regulator, but it is actually mandated under the Disability Act. And that's why we are also partnering with SPIDER into doing a little pilot project, which I will touch on later on. And our website has a lot more information and guidance documents and resources, which some of you might find helpful, so feel free to check it out. So why do we need to reduce chemical restraint or psychotropics? I think the term chemical restraint can be quite contentious, but essentially we know that for people with an intellectual disability, they are on more psychotropics than the general population for various reasons and valid reasons. But when we look at our data, because all the medications that are used to manage behaviours of concern need to be reported to us, around 2/3 of the people who are on chemical restraints, they are subject to polypharmacy. And polypharmacy alone can lead to increased risks such as respiratory depression and metabolic syndromes. So a lot of those side effects for people with intellectual disability, they're already at an increased risk of. So this just compounds the problem. And also 3/4 of the people who are on chemical restraint are prescribed antipsychotics. Now, we know there is a lot of harms with antipsychotics, such as movement disorders, and again, the metabolic side effects, such as weight gain and diabetes. But there is also emerging evidence of increased risk of unexpected deaths in children and young people who are on high-dose antipsychotics who do not have a mental health diagnosis. And again, this is mainly due to the cardiometabolic liability that's caused by antipsychotics. We're also seeing an increasing trend of increased use of benzodiazepines. Despite the lack of evidence to support their long-term use for any condition. This could be attributed to COVID with all the disruptions, but also the transition from state-funded services to NDIS. So we're hoping to see that it will come back down once things start to settle. But again, I guess based on past experience, we know that once medications are initiated and doses are increased, it's very difficult to bring them back down or cease, even when they're no longer required. And also historically, chemical restraint is not really addressed as part of the positive behaviour support process because it is seen as being out of scope, given medications is a specialised area. There's not much collaboration between positive behaviour support practitioners and prescribers, and there is not a lot of quality data sharing between all healthcare providers. We know that there is a lack of confidence in the sector in, first of all, identifying what is considered chemical restraint, and certainly subsequent strategies for a successful fade out, and that's across the board. Even GPs are not confident with that process. And as always, there is the lack of resources, and that's both in terms of financial staffing resources or expertise and support. The landscape, I guess, has changed quite a lot lately. There's an increasing focus on the use of psychotropics. And recently, the three commissions have released a joint statement on the inappropriate use of psychotropics to manage behaviours in people with intellectual disability. They recognise that there is little evidence for efficacy when used purely to manage behaviours of concern. There is an evidence of overprescribing, and that those medications can cause significant harm and reduce quality of life. And we know that many people with intellectual disability, they are receiving polypharmacy, as I mentioned, in high doses and also for long periods of time without proper review at times. So what have we done so far? So since I've started, our team has been reviewing our existing policy to refine it by, first of all, identifying a lot of the inconsistencies in practice advice. We've been reviewing the common inquiries that we get through our external email, which is riquestions@dffh.vic.gov.au, which we receive mostly questions from APOs regarding chemical restraint and other restrictive practices. And we've been analysing our data to identify some of the priority areas, such as high-risk medication combinations, and certainly polypharmacy is and has always been a priority for our office. We've consulted the sector to try and identify the practical barriers to change, including gaps in practice support. And we've been refining and working with a lot of experts in different areas to refine our internal policy to make sure that it's contemporaneous with current evidence, and a lot of the rarer conditions or some of the new issues that have come up, such as psychosocial disability, just consulting with the experts to ensure that our policy is still fit for purpose. And we've been looking at developing some resources to target those common areas of concern or to address some of the knowledge gaps. So they're in drafts at the moment, and we've been seeking external feedback currently. And once they are ready to be released, we'll probably hold a session to the sector and go through those resources in an interactive manner. So the next steps, one key focus will be building capacity in the sector. That includes a focus on how data is captured and shared including how chemical restraint is reported in line with the NDIS Commission with the quality of behaviour support plans. So we'll be doing some work around how we can improve the way PRN protocols are written and how fade-out plans are written within the behaviour support plans. I will touch on Spectrum later on. That's part of the STOMP project. And also looking at how we can improve the understanding of psychotropics, especially in terms of monitoring for the side effects. We will look at performing some targeted activities such as audits for particularly high-risk clients with medication just polypharmacy mainly, or high-risk medication. Sorry, I've just got to turn the light back on. I'm one of 3 people in the office today, so there's not a lot of movement and the light just turns off. And we will continue to look at how we can collaborate with other organisations to make sure we're not duplicating our work. And also that includes other areas within the department. And another key focus is to strengthen our relationships with prescribers because we know that medications start and stop with the prescribers. So that's one area that we are definitely going to focus our efforts on. And one part of that is the pilot program that we are planning to start in partnership with the SPIDER team in the Western Vic area to look at how we can work to reduce the use of psychotropic medications. So this pilot program is, I believe, the first time that in Australia we've tried this approach where it's a multidisciplinary approach to look at how everyone can work together to reduce the use of psychotropic medications. Now, we know that there's been lots of projects done in the past to try and tackle this issue. And unfortunately, nothing much has shifted, and it is a very complex and difficult area. So the idea behind this pilot is that we want to see how the different sectors, which at the moment can be quite fragmented, can come together and develop the plan together to try and rationalise the use of psychotropic medications. So along with the SPIDER team, we have partnered up with a few disability service providers, CDDH, and the Spectrum resources and the NDIA. So the Spectrum resources are provided by a psychiatrist in the UK, Dr. Shumi Deb. So he developed these resources a while back as part of the STOMP project in the UK, which has been quite successful. I can't remember what it stands for exactly right now, but it is to essentially to stop and reduce the use of psychotropic medications in people with intellectual disability. And this project, so the Spectrum resources were developed specifically to target support workers and carers to improve their understanding of medications, particularly around the potential harms, and also alternatives to medication. So the foundational principles behind positive behaviour support. And the idea is that the support workers or the carers are then equipped to identify any issues such as side effects or lack of effectiveness from medications, but also to understand and not put pressure on the prescriber to prescribe and look for the causes behind the behaviour, if a new behaviour emerges or if it worsens, and bring that to the attention of the relevant healthcare provider. So with this pilot, we will be involving support workers, families and carers to undergo this training with the Spectrum resources to upskill them in this area, but also we're looking at working with the behaviour support practitioner, a consultant pharmacist who will do a comprehensive medication review, and also the GP to come up with a plan to try and reduce or rationalise the use of psychotropics if it's appropriate. And the idea is that, along with what Nicole was saying earlier about the health journey and really sort of targeting all the different interface and the person with intellectual disability, how they engage with each health care provider, to really follow them through this process, starting support workers and families to when they are having a comprehensive or interim behaviour support plan done by the behaviour support practitioner, to the having a medication review, and then lastly for the GP to look at all of the information and recommendations together, and then obviously feeding it back in terms of implementation and monitoring to track whether the recommendations or changes in therapy are working or not working. And this program will involve upskilling to all the different healthcare providers, health professionals, to address any knowledge gaps and provide real-time support, because that's, I guess, one of the key areas that prescribers have been asking for, and so far there has been limited support in terms of individual patients. We know that services are quite limited in the area of dual disability. So I guess in terms of evaluating what would be considered a success for this pilot would obviously be looking at medication usage, along with the behaviour data. We would need to track that to ensure that when medications are changed or reduced, that it doesn't lead to worsening of behaviours of concern or destabilising the person. But also we're keen to get a lot of qualitative evaluation done with the healthcare providers to get a more nuanced understanding around the practical challenges or various aspects of the program or training and implementation to inform future work that we plan to do, as well as the resources that we're using. So for the support workers and carers, that will be Spectrum, which has been evaluated and has been used in the UK and also in Australia recently. But we also want to evaluate the educational materials provided to the GPs.